Hello, and welcome to your second look at Michigan medicine at the University of Michigan. We are so excited by your interest in our training programs. I am Marcia Perry. I'm a faculty in the Department of Emergency Medicine, and I'm the Associate Chair for Diversity, Equity, and Inclusion in my department. I'm also the faculty lead for our House Officer programs in the Office for Health Equity and Inclusion. This program that we present to you today is sponsored by the Office of Health Equity and Inclusion and the Office of Graduate Medical Education. We thank them both for supporting this program. We'd like to start off our program today with the leaders in our sponsored space, Dr. David Brown and Dr. Silva Biermann. Dr. Brown is the Associate Vice President and Associate Dean for Health Equity and Inclusion and the Associate Professor in the Department of Otolaryngology. Thank you, Dr. Brown, for kicking us off.
Thank you so much, Dr. Perry. Good evening, everyone. On behalf of Michigan Medicine, the Office for Health Equity and Inclusion, I would like to welcome each and every one of you virtually to Michigan Medicine. It's so amazing to see over 450 people on this Zoom right now. Thank you for joining us for our second look event. This year's theme is Health and Justice, a Threat to Everyone. And this is critical as it highlights the importance of diversity, equity, and inclusion and anti-racism and health equity here at Michigan Medicine and the national and global impact we as healthcare providers and current and future leaders have both in medicine and beyond. At Michigan Medicine, we work to create a collaborative environment where diversity, equity, and inclusion and health equity is weaved into our culture. Our core values of caring, innovation, integrity, teamwork, and inclusion are emphasized at all levels of our institution and work congruently across multiple strategic initiatives to serve as a model for which we work, learn, heal here at Michigan Medicine. Over the course of the last weekend, you might have heard news that the University of Michigan president was removed from his post. Our Board of Regents fortunately acted swiftly in dismissing the president for inappropriate conduct that left him out of compliance with the very University of Michigan policies that he introduced and enforced regarding gender and sexual misconduct. I just wanted to be transparent about that. The immediate actions taken by our Board of Regents is confirmation of the accountability, transparency, and commitment to professionalism and justice at the University of Michigan and Michigan Medicine. These actions are consistent with our institutional values of no tolerance for sexual misconduct, supporting gender safety and equity in the workplace, and continuing to develop a healthy culture that values diversity, equity, and inclusion. Michigan Medicine is one of the largest academic training sites for House officers in the United States, if not the largest. And it's through our demonstrated efforts that we have successfully increased our ethnic diversity amongst House officers. When I first took over as the Associate Dean for Health Equity and Inclusion in 2016, roughly 3.8% of our House officers identified as underrepresented in medicine. And in 2021, 9.3% of our House officers identify as underrepresented in medicine, meaning that in 5 years, we've more than doubled our number of underrepresented and diverse House officers here at Michigan Medicine, a number that we continue to expect to grow over the upcoming years. And keep in mind, we value diversity, equity, and inclusion in all forms, and diversity in all forms, and we value and welcome people of all identities and intersecting identities, because that's what makes a rich environment for us to learn and to grow here at Michigan Medicine and to take care of patients in an equitable fashion. We are living in a time now where more than ever, we must meet the demands for equitable healthcare for all. It is imperative that we all work together to dismantle the systems in which inequities were created and advocate for healthcare and health justice. In the Office for Health Equity and Inclusion, our vision is to create a world where every person feels valued and can thrive. This includes diverse communities and marginal populations within our walls and within the communities surrounding us. Throughout the course of today's program, you will learn more about the support, resources, and opportunities that are available at Michigan Medicine to equip our healthcare teams to be leaders and change agents in health and healthcare equity. Again, welcome to Michigan Medicine. Thank you for your participation, and go blue. I'll pass it back to Dr. Perry.
Thank you, Dr. Brown. I'm going to next introduce Dr. Silva Biermann. Dr. Biermann is the Associate Dean of Graduate Medical Education and Professor in the Department of Orthopedic Surgery. Dr. Biermann is going to talk with you about resources here for house officers and just an overview of GME in general. Thank you.
Thank you so much. I really appreciate it. And I'm delighted to be here, and welcome to all of you. And I hope to see so many of you coming in our classes in the coming year. I'm going to give us just a brief overview of some of the resources that we have to support house officers in terms of salary and benefits here at the University of Michigan. And I want to thank Dr. Brown and reestablish and recommit our strong dedication to helping all house officers be successful here. And I've been delighted to work closely with Dr. Brown over the last 5 years as we reconfirm our commitment in both environment here as well as recruitment. So thank you. Next slide, please. I'm going to talk a little bit about salary and benefits. As I mentioned, we are very pleased to offer highly competitive salaries. These are competitive both in the region and in the nation for our house officers. These have recently been increased, and we have a starting house officer salary at $64,000, and our highest level at House Officer 9 at $94,000. Next slide, please. In addition to our annual salary, I'll go back one, please, if you'd be so kind. In addition to our annual salary, we also offer a lump sum payment. This is paid to all house officers who are present for an entire year, and this is to encourage savings. This represents 1/10 of the annual salary and is paid in a lump sum generally in the autumn. Next slide, please. We offer a very competitive benefits package, which I'm going to talk about a little bit in some detail. We offer health insurance coverage, which begins the first day of employment. We offer managed care, fee-for-service health insurance plan options of a variety so people can select what works the best for them. Prescription drug benefits are also included. Additional benefits that we offer in addition to health insurance that are available for all house officers and supplied by the University of Michigan and Michigan Medicine include life insurance, professional liability insurance, that is to say medical malpractice insurance that starts the day you work and continues on after you leave for the time that you were here. We offer long-term disability. We do have paid leaves of absence for serious illness, bereavement, maternity and parental leaves, military and FMLA leaves. Additionally, as needed, unpaid personal leaves may be available at the discretion of the program. We offer both maternity and parental leaves. So with regard to maternity leaves, we offer 6 to 8 weeks, depending on mode of delivery. We also offer some relief from duties for the last trimester and for the post-peripartum period regarding overnight call and duty hours limitations to 12 consecutive hours for post-delivery mothers. With regard to parental leave, we have 6 weeks paid parental leave for a house officer who becomes a parent. And this includes both the non-medical parent as needed. So birth mothers who take maternity leave also can use parental leave in addition, as well as for other parents who become parents during the time of their training. We have optional benefits available, including a dental plan, a vision plan, optional life insurance, dependent life insurance, a legal plan, and flexible benefits for healthcare independent care. Next slide, please. In addition to our competitive salary, we also have additional time off for holiday pay. So if you are on call during a scheduled holiday, you also get an additional supplement of 1/365th of your annual salary. We offer a competitive vacation of 28 full days of vacation for all house officers. Additionally, in addition to vacation and holiday pay, all house officers receive 1 personal day per program year to be used for personal needs. And those can be used in half or full day increments. And we have additional time paid off as required for required examinations, life support training, and other requirements that your program may have in terms of other licensure or evaluations. Next slide, please. We are very concerned about the wellness of our residencies and the well-being, and we recognize that even in regular times, training is stressful, and certainly during the time of the pandemic, it's extra stressful. So I'm going to talk a little bit about our mental health benefits in particular. We have long since offered a house officer mental health program, which provides direct access to psychiatrists with experience and expertise in supporting house officers. This has been in existence since 1996, and it provides a range of mental health services and provides a broad spectrum of mental health needs as listed. Next slide, please. In addition to the specifically tailored house officer mental health program, we also have available to all staff, faculty, and learners at the University of Michigan, the Office of Counseling and Workplace Resilience. These are available 24/7. These services are confidential, free, and available to all Michigan Medicine faculty, staff, and their immediate families as well. And this provides assessment, referral, consultation, and short-term counseling services for folks. These are now available virtually, can be done video, can be done in person. Primarily, this is virtual at this time now. And this provides tools to manage stress and burnout. Next slide. In addition to those benefits, we also offer a cellular phone stipend. We recognize that house officers frequently use their cell phone for employment-related activities, and to acknowledge this, house officers are eligible for a $50 monthly cell phone stipend. We also offer meal allowances depending on house officer hour allocations and hours worked. All house officers do receive $100 on their M card, which can be used for meals within the hospital system. And that's at one time at hires, in addition to the call money that's given as well. We do reimburse for the USMLE Step 3. And lastly, we do have a wellness center, which is actually a small gym. And all the house officers are eligible to join this. It costs $10 per month. It's nice to have access to this if you have short amounts of time between times. We recognize that house officers are often at the hospital for long periods, and we want to ensure that they have some access to exercise facilities. Next slide, please. Thank you very much. This concludes my brief summary. Again, welcome to all of you. I'm so glad you could all join us today, and I'm really looking forward to the exciting program that our colleagues have put together. Thank you.
Thank you, Dr. Biermann. Our GME office, in keeping with the ACGME, is committed to diversity, equity, and inclusion. We're deliberate and mission-driven in addressing DEI issues at our institution. We have a GME DE&I subcommittee, and also called the DE&I Social Justice Subcommittee. Dr. Matthew Wickson from anesthesiology will be talking to you about that program. Dr. Wickson is the Associate Chair for DEI in the Department of Anesthesiology and also the Associate Professor in Anesthesiology. Thank you, Matthew.
Thank you, Dr. Perry. And welcome to all of you for being here today. It is so life-giving to see nearly 500 of our amazing applicants here talking about these important issues. So I'm Matt Wickson. I'm an anesthesiologist here and a near lifer here at Michigan, starting in medical school. And why do I stay here? Because it's an institution that really cares about issues that I care deeply about. And a special thanks to Dr. Biermann for dreaming up and creating this subcommittee on diversity, equity, and inclusion, of which I co-chair. So we are a relatively new committee. We're conceived about a year ago to bring all of the GME community together. As many of you have likely experienced and seen in your own institutions and on a national level, many people are committed to diversity, equity, and inclusion, but they're doing it in silos. They're doing it on their own. And at times they could be reinventing the wheel. And as a GME community, we believe really deeply that we actually just need to be working together on these issues, that there's strength in numbers. I'm an anesthesiologist, and I know my department benefits when otolaryngology and orthopedic surgery and general surgery and everyone within the hospital and the people I work with are more diverse, and we're talking about these issues and we're committed to them together. So that's where this committee came from. Our composition is faculty and house officers working hand in hand. And our first major project of this past semester, you all benefited from. We took a deep dive into how we interview here at the University of Michigan. How can we make it an equitable experience? How do we make sure that our interviewers from start to finish, the entire process decreases bias? And when bias rears its head, how do we talk about it in a professional and appropriate manner so that we can eliminate it from our processes? We spent a lot of time educating all of the interview committees, from the people who screened your applications to those you got to interact with on Zoom, so that we know how to have these conversations. We can speak intelligently and logically about the efforts here at the university and also within our departments and how we're working together. We're really pleased with how that first project turned out. Our feedback has been excellent, but you all are the most important feedback. So please, when you get the surveys from the departments, answer it. Talk about if you experience bias. We need to know those things because we want to continue to grow and to get better and make sure we have a welcoming, inclusive environment. Our next project that we'll be turning to as a committee is to really start looking at how we educate about health disparities and health equity across the GME space. It's incredibly important for us to understand the different patients that we may be taking care of as they come to us, the barriers they face, the social determinants of health, things that we're starting to get a taste of in medical school. Really, we want to create a robust institution-wide curriculum that will be available to all house officers, so that when you leave your training here, you are armed with the tools that you need to go out and have an outsized impact on whatever institution or group or department you join next. We know that it's going to take all of us doing this work together for us to affect change. And there's a lot of work to be done. And our committee is so excited that we have such a diverse group of individuals from across the GME space, really helping us with this work. So that's just a preview of what our committee gets to work on. Again, a deep thanks to Dr. Biermann for her sponsorship and her mentorship and all of the GME leadership, because they've put resources and time into this because it really matters. And as a community, we see its value. Thank you all for being here. And for those going into anesthesia, I can't wait to see you in the breakout room.
Thank you, Matthew. Dr. Michael Lucella co-chairs this DEI and Social Justice Subcommittee, and Dr. Lucella is our next speaker. I want to check in if he was able to join us because I know his clinic was running a bit late.
Not yet.
Not yet.
Well, great. Well, we have an annual tradition here at the University of Michigan called The Smoker, which is a parody musical often put on by medical students. I got the good fortune of playing Dr. Lucella several times in The Smoker as a student. And so I'm going to play him again right now. And I'll happily welcome our panelists.
Okay, so I guess I'm going to introduce Matthew again as Dr. Wickson is going to moderate a panel discussion around the supports that are here. If you happen to be leaving your home with your friends and your family, whether California or New York or wherever you're coming from, what supports are here at Michigan to help you transition from warm, sunny Florida to Michigan medicine? Matthew, you're on again.
Excellent. So I'd like to welcome Dr. Shukri Duale, Daniela Sosa, Dr. Fitz-Tavernier, and Dr. Brian Martinez. I'll give you a moment all to get pinned.
Hi, everyone. I can start first. My name is Daniela.
If you could tell us about yourself, Danielle, your background, where you have done your training thus far, current training program, year in training, and what you're going to be when you're all done.
I did my training in Miami. That's where I was raised. I went to medical school at FIU, Herbert Witham College of Medicine, and I am a first-year medicine pediatrics resident. I am not entirely sure where I decided to do after residency.
Thank you so much. Dr. Duale.
Hi, I'm Shukri Duale. My family's originally from Somaliland, but I grew up in Buffalo, New York, and I went to med school. I went to college at University of Rochester in Rochester, New York. Went to med school at Drexel University in Philly, and now I'm here for a general surgery residency, and I'm a third year.
And what are you going to be when you're all done?
Yeah, so I'm still figuring that out. I have a long list of stuff I don't want to do, but you know, I'm still trying to explore and see what to go into. So a couple options are either thoracic, surgeonc, or potentially ACS. We'll see.
Fantastic. Dr. Tavernier, I believe you are on as well. Oh, you're on mute. It had to be someone during the Zoom, so there we go. You actually muted yourself again.
Can you hear me now?
There we go.
All right, bet. Yeah, what's up, everyone? My name is Fitz, or Dr. Tavernier. You just call me Fitz. I'm only a PGY too. So I am a second-year anesthesia resident here at Michigan. I also went to Michigan for undergrad, as well as med school in the MPH here. So I've kind of been at Michigan for a while. And I am interested in most likely probably pursuing a critical care fellowship through anesthesia. Yeah, I'm from Michigan as well, Grand Rapids area.
Fantastic. Well, thank you so much to the three of you for being here. We're going to get right into the questions. So my first question for you is, how were you able to get a sense of the climate and support here at Michigan? Especially if you had to assess it in a virtual format.
Well, right off the bat, I received emails from residents introducing me to the program, and just having someone to ask questions to. It was always like an open line of communication. Everyone was very forthcoming, and the pre-interview like Zoom events were very helpful in just knowing the climate and just the culture of exactly how everyone really is.
Yeah, so for me, I did interview in person, so it was a little bit easier, but I completely agree. For me, it was speaking to residents who were here already, from all different types of backgrounds. So I spoke to minority residents who were ahead of me and specifically asked, what sort of support have they gotten while they've been here? And, has the department been able to come through for you? And then also asking other residents, what they do to support their minority core residents. And so really, I completely agree. It was really just having that support, that reaching out to the residents and specifically asking them those questions.
Great, thank you. Fitz, do you have a comment on that as well?
Yeah, well, for me, I guess I was a little bit, I already kind of had the upper advantage because I had some idea of what the atmosphere is already like as a medical student. And so That's kind of translated in somewhat to a resident, even though we're playing a different role in the hospital. I think talking to other residents about, specifically other residents that were here for med school, that's how I did, and see if they felt any different from as a resident. Did they felt like the culture was different, more or less the same? Did it change? And if anything, I probably saw that it translated as just about as the same amount, as much support as I felt as a med student here, which is why I stayed in the first place. And honestly, I was highly considering leaving for residency because I've been at Michigan for so long and so much. But I felt, part of this could be biased, but I did feel like I couldn't find that same type of support and culture and community that I had at other places where I interviewed. And that was in person, so it wasn't virtual. And so long behold, I did end up staying. So yeah.
Great. Well, thank you all. Fitz, I remember a particular conversation that you and I had for about an hour on the phone talking about this very thing. So that point is well taken. Talk to the residents. They will tell you the truth and are happy to talk about this place. My next question is, if you can think back to when you were making your rank list and putting Michigan, top of your list, what factors were important to you when you were trying to decide to train here at Michigan?
For me, I guess I can jump in. Honestly, the biggest factor for me, I knew regardless going into anesthesia or wherever I went, I was gonna come out as a pretty well-seasoned trained anesthesiologist. The biggest factor for me was actually going into a program that I felt, for one, had people that looked like me, and for me, that identifies as a Black male. But then two, also an environment that not only tries to, recruit diverse background from race, gender, sex, ethnicity, all that. But what are you doing to support them once they get here? Because it's easy to kind of just have a number on the stat board and be like, look, we have our numbers. Look, we support all these different backgrounds, all these different people. But then, like, once they get here, what are you doing? And so I felt like I wanted to go a program that had both of those two things, because I knew the rest was going to come. I knew I was going to get the training. I knew I was going to get the patient experience, the exposure to different cases and things like that. That's kind of more or less the same. And so one of the biggest things for me was, specifically in the anesthesia department, there was a big change in the leadership, and starting with our new chair, as well as Dr. Wickson himself. And there was a lot of new leadership roles being implemented and being in place. And this was kind of long before, I like to say that I think DEI became a fad within the last year or 2 years after George Floyd. And I wanted to go a place that was actually already doing DEI work well before that. So it was proactive as opposed to reactive. And that's one of honestly, the biggest reasons why I ended up staying here. Those are the two biggest things for me. And then outside of that, even just like as a resident, what is it like as life of a resident? Do you feel like financially you are living paycheck to paycheck in the city that you're living versus the compensation? And then also the union, the House Officer Union here was also one of the biggest things that and we'll probably talk about that later, but one of the things that drew me to stay, because there's not too many unionized residencies, and that vouched a lot for us in so many different things.
Right. That's great. So, hello. Thank you so much, Matt, for stepping in. I apologize for being a couple of minutes late. I'm Michael Lucella. I'm the MedPeds program director, and also the vice chair for diversity, equity, and well-being for the Department of Medicine. And Matt was kind enough to step in. I am actually finishing up staffing a clinic with one of my residents at the Hope Clinic, which is a clinic for the uninsured in Ypsilanti. And we had a couple of things sort of come up like last minute, and obviously it was incredibly important for us to pay attention to the needs of the patients that were with us. So I really appreciate your understanding and me being a little bit late, and Matt for jumping in. I'm not sure, Daniela or Shukri, if you would like to sort of add to how Fitz had started the conversation.
Yeah, I definitely agree with all he said. And then in addition, I think, having already established DEI, I guess, things for the institution and for the organization. But I think what sets Michigan apart is just the desire to continue improving on itself. We can all just, do organizational changes and regulations and rules and have programs as such to help diversity and inclusion. But I think Michigan goes above and beyond on wanting to improve and constantly asking, what are ways, or having different events, or having different ways for residents to be able to speak the truth and speak from what they've experienced, and validate those experiences by listening to them and just always evolving. So
Yeah. And so I think in terms of practical things, so for surgery, I knew specifically, I looked ahead in the residents that the program has graduated, and they have all gone on to do amazing things. So I knew coming here that I would get amazing training. I would graduate with great surgery skills. And for me specifically, I didn't have much experience with research, and that's huge in our department here. So I knew that that was going to be a new set of skills that I would gain training here. And I, again, just asked the residents try to really delve deep into what type of culture it is here. And I wanted to be in a program where the residents supported each other through whatever they were going through, and people who covered for each other and looked out for each other. And that's definitely something that I sensed here. And then in terms of, DEI, like being in a diverse either city or program was important to me. Ann Arbor isn't the most diverse in terms of race and ethnicity and multiculturally, but there's a big socioeconomic sort of diversity throughout Michigan, especially because we see multiple patients throughout the state and neighboring states. So that was a pro for me. And then also just, I specifically wanted to know what the department, if they had like intentions of increasing their diversity, because when I looked ahead, there was only one minority resident in the class ahead of me and one more in the class ahead of that. So basically like one per class, but they specifically had intentions and plans put forward to increase their diversity. And not being a third year, I look at my class and below, and the class that they graduated 7 years from now is completely different sort of face and background than the class that they are graduating behind. So it's, I'm really grateful that there was true action put behind the words.
Maybe to expand on some of the themes that each of you has shared. Shukri, you were really highlighting that diversity takes many different forms in addition to race and ethnicity and gender. And I would love to hear your collective perspective about kind of describe what is the DEI climate like here, and do people, whether they may identify more closely with a minority group or a majority group, and kind of depending on which sphere you're sort of talking about, do they feel valued?
Yeah, I think what I was a happy surprise and something that I didn't think that much about was not only within my department, but within other departments. So I, of course, I'm close with the people in my residency program of all different types of backgrounds, but we also have a close community of minorities throughout every residency. Like I could tell you, I have a friend in every residency program here, and that's something that. And I came from Buffalo, and again, like I lived in Philly, but coming here, I didn't know anyone. So that was something that I am so grateful that I have now, because when when you're working 80 hours a week, it's hard to kind of process real life things that are going on. And Fitz touched on George Floyd, and it's interesting how you can, when you're in med school and going through residency, kind of feel isolated if you're not around people who look like you to really understand like what you're going through. And coming here, and finding that community was something that was incredibly important to me, especially given, recent years. So definitely reaching out to other programs and then finding our own communities. So I'm just grateful.
Great, Daniela or Fitz? It's always hard because you can't tell who I'm looking at. Just like looking like straight at the camera.
Yeah, I just agree. I have nothing else to add.
Okay. And thinking about this from the perspective of, because each of you is in, well, I guess you and Fitz are in similar years of training. And so thinking about what was that transition, how has the transition been specifically during your intern year? And I think Shukri can sort of reflect on, now that she's been here for a few years, about how her perspective may have grown and changed over time. But I'd be curious to sort of learn a little bit more about, especially the two of you went through this in a virtual environment and trying to get a sense and a feel for the climate and sort of what Michigan medicine really sort of proverbially felt like without physically sort of being able to visit, and then sort of how and what you've experienced during your intern year would be great.
Yeah, so intern year is hard regardless of where you go, what you do, what specialty. And it was also a very trying intern year, time-wise, at least for me, given the racial climate that was going on 2 years the summer, literally I was going into intern year. And so I think the transition for intern year was one, from just a medical standpoint, like just from a medical background, like understanding the differences of being a doctor, being a physician as opposed to a med student. So that's a whole nother transition in itself. So that in combination of some of the, I think regardless of where you go, you're going to have microaggressions. And I think those microaggressions are a little bit more apparent as a physician than they were as a med student. Now, because that I'm in a different role with more responsibility. And so those microaggressions can come from patients. They can come from, other people that you work with. And it's not like they're not always there, but I think they're a little bit more heightened, or I was a little bit more aware of them as I was a physician now. When those responsibilities came and when I had different interactions with, patients or other people, there's really just one in my mind that I think that kind of happened that came from a patient. And I remember going home and feeling very, very down about it. And it was around the same time as the climate of all this happened. And I remember reaching out to a lot of people within, or just a couple people, actually, just people within my department, and just chatting with them about what happened and how is this transition different from me just trying to focus on the medicine, but also how do I exist in this world that may not see me in the same eyes as I see myself. And so I say all that because, no matter where you go, these things are going to happen regardless if you're whatever you may identify as. But I think what made me feel supported was that I got, like emails from people within my department, people I never even met, like, hey, Fitz, no, you're in our department. We haven't met you yet, but I heard this happened, and I just want to reach out and let you know, see if you're okay. And even Dr. Dimmick, the chair of surgery, had reached out to me, and it's like, I'm not even in his department, but like he, so I felt really supported that I could, share some experiences of things that would happen. And there's people who I know from my department reach out to me. But then on top of that, there's people who are in other departments and people who I've never met that maybe just heard on the periphery, and reached out and to kind of see like, how are you? How are things? Is there anything I can help you with? Like, feel free, my line is always open. And that felt really nice because it's hard to find that. And especially, I think it speaks to the climate of Michigan as a whole, regardless of what department you're in, is that you're not just a person in a specific area. It's really kind of like holistic, no matter where you come from. You're part of the Michigan family, regardless of where you're at. And so that was pretty cool for me. And that transition, I think, was heightened as I went into intern year.
I can 100% agree with that. This is my intern year, so I did do a virtual interview season. It is difficult to sort of think about, what is the truth, or what is like what the picture that they're painting you. And I think, in choosing Michigan as a residency, I'm so grateful. I'm so happy to be here. I really feel like I'm a part of a family. I am in the medicine pediatrics residency, and so we are a smaller bunch. But either way, even in the medicine side and in the pediatric side, I definitely feel included in all of the both residencies and in my own residency. And people are always checking up. I have various senior residents are always, intern year is really hard. Like, how are you doing? Always asking, any other help, if I need any help, offering to help with various other things that have happened, like through intern year. I drove here from Florida, which was a very long way, and I remember getting here and it was pretty late, and one of my Melissa Ross, she's a second year med peds resident, and she very late so kindly offered me her mattress because I didn't have a mattress. I was going to sleep on the floor, and she very late I had gotten in to Michigan and to Ann Arbor, and she helped me carry her mattress from her apartment to my apartment, and it's just it's really the small things that really add up and make you feel as part of a family, and that's what Michigan has become for me.
And I just want to add one thing to that. So the theme is support, right? And it's regardless of what you're going through. So residency, especially for surgery, it's 7 years here, and a lot of things will happen during that time. You'll go to weddings, funerals, celebrations, you'll move, and you just want to make sure that you go to a place that regardless of what you're going through, people are checking in on you and are there for you. And that's definitely something, just hearing Fitz and Daniela say, that's here in multiple different departments. So.
Right, and I really appreciate each of you sharing some really terrific examples of your experiences here. I would completely echo those sentiments, and sort of reflecting back, I remember when I was a resident, which you can sort of put in how long ago that was and stop laughing, Fitz. It wasn't maybe that long ago. I remember many of those very same sentiments. And this, to give a context, it has been over 20 years since I started my residency. And it's wonderful to hear that those themes continue to endure. And as a faculty, having been through training, has been something that has been very resonant, and it has been one of the key things that has kept me here all of these years. But I'd love to expand the conversation a little bit. And so we've been talking about the climate and the support within Michigan, within Michigan medicine. And I wonder if you could share some insights about Ann Arbor in the state of Michigan and the community, understanding there might be some aspects in particular for Daniela and Fitz that have been a little harder to see and experience fully, just by virtue of the pandemic that has been sort of going on, which has limited some of the activities that you might usually be engaged in. But would just love to hear about how you've been engaging within the community, thinking about cultural opportunities that might be happening sort of within and outside of the hospital.
Lots of outdoor events. It's been really lovely to be a part of the art festival in the summer, and going out to like restaurants typically are good for like, you know, drive-bys, and you can take out, and the food has been really great. There's actually a very big vegan community for those that are vegan. There's all types of things. I'm from Miami, and you think of Miami as this big melting pot. It's just all Hispanics. So here it's been really great to like you know, like eat all Asian food and like Vietnamese, and it's been pretty good.
And then for
Yeah.
me,
Yeah,
go ahead. You want to go?
You go.
Well, so for me, I think for one, which I'm surprised, Ann Arbor is a little bit different for me now as I guess an adult, as opposed to when I was that, you know, little kid in undergrad. But I think what's nice is that the medical campus is separate from the undergrad campus, so it doesn't fit. So I say that because you get all the benefits of being in a college town without feeling like you're in a college town, you know, walking around with a bunch of 16, 17-year-old, like you still get the college town feeling, which is nice because that comes with a lot of perks and a lot of benefits. So one, Ann Arbor being such a big, or University of Michigan itself being such a big institution that prides itself in both academics and athletics. The athletics part is pretty huge. And so, you know, we have the biggest stadium in North America right down the street. And the big house, you know, holds over 114,000 people. And football games, you know, I still went to them in med school. I went to 2 or 3 in the last 2 years in residency. So always trying to pick up, even if you don't like athletics or you're not a sports person, it's always cool to just at least go and see a crowd like that. And then on top of that, you know, basketball, hockey, there's the whole gamut of things. And then Ann Arbor itself is a pretty, you know, outdoorsy place. So if you like to do outdoorsy things, you know, the arbor itself means tree. And sometimes I forget how many trees there are in Ann Arbor until I go to like the top of 12th floor Mott, and I just look, I'm like, wow, Ann Arbor's a lot of trees, but when you're driving, it doesn't seem like that. And so, you know, there's the Huron River that runs right down the middle of Ann Arbor. People go kayaking, canoeing, tubing down that every summer. And then there's a lot of like hiking and different trails like that, as well as biking trails and running trails if you're a runner. And then on top of that, as Daniela said, there's a lot of festivals, especially during the summer. There's an art festival where they shut down the entire downtown. And Ann Arbor, it's kind of like I'll say you'll have people who argue against this and for it, but I think it's a foodie town. So I think there's a lot of great restaurants. And then even if you'd like to go and access to a bigger city, Detroit is right down the road. It's 40 minutes from here. I know sometimes media may portray Detroit as, you know, negative or unsafe, but I go there all the time, and it's beautiful down there, especially during the summers. And so it has the perks of a big city right down there, as well as if you'd like to travel. Ann Arbor is pretty close to the airport. Chicago is only 3.5 hour drive. Toronto's only 4 hour drive. And so, yeah, I think there's a whole gamut of things depending on what you'd like. And there's even a good bar scene. Like if you like to go downtown and bar, have drinks with friends, there's open beer gardens and things like that. So, yeah, those are just a list of a few things I've enjoyed about Ann Arbor.
Yeah, you got the whole spiel. I love it. That's perfect. I totally agree. And then the airport is only like 20 minutes away, depending on where you live. But so you can easily hop on a flight and go somewhere. So, but yeah, I totally agree with what everyone said. Floating down the river is my favorite summer activity.
Facts. And then one more thing is, I think again, being in a town with over 30, 40,000 people, the traffic is actually not that bad. And so you can get to anywhere you need, grocery store, running errands, the bank, anything within 20-minute drive, maybe 30 minutes max. That's a lot, but everything is like within reach. So.
It's funny that you mentioned the floating. So in the middle of January, there's maybe not as much floating down the river as it were. But yeah, I think on most weekends, like there's like a multi-specialty group like of residents like floating down the river and, you know, different sort of points in time, which is really pretty neat. And also like paddleboarding, canoeing, that kind of thing as well. Yeah, one thing I was a little surprised you didn't mention this, Fitz, that like Wynton Marsalis, like he comes here pretty much every year to play, and so as part of the university itself, one of the, I think, benefits is that, so we have a university medical a musical society. And so they bring in some really just fantastic performers. And so it ranges from, you know, the Martha Graham dance company to the London Philharmonic to, I mentioned, like Wynton Marsalis or Yuja Wang. And so the nice part is that like the residents, when you're in training, so for those types of things, you're considered students in terms of like the ticket prices, which is awesome. And then for other things, you're considered sort of faculty. And so it actually works out really pretty well in terms of the different opportunities that sort of extend beyond what the three of our panelists have shared. I'd love to, as we're getting, or as our time is sort of drawing near, so maybe if each of you would mind sharing one piece of advice that is really important that you would sort of share with the applicants who are here for them to sort of consider as they are trying to make their respective decisions. And one thing that you're looking forward to at Michigan, like during the next year or two. So I can give you a minute to sort of digest that.
I think in general, when you're making your rank list, truly make it for you and only you. And, you know, don't worry about what you hear from programs, what they're telling you, what, you know, or what sort of like responses you're getting. And, you know, even people in your personal life, just make sure that when you submit that rank list that you'll have no regrets in terms of the order. And you just truly want to rank them truly to stay true to yourself, and that's really what you want. And if, you know, location is really important to you, that's definitely something you should prioritize. If being your family is important to you, that's something you should prioritize. If the makeup of the program is important to you, that's something you should prioritize. So just know what you want and what your priorities are. And the reason I say that is because if you approach it that way, then no matter what happens, you can look back and have no regrets. And I think that's the most important thing. And then the thing I'm looking forward to is our program here, so we do 3 years of clinical years, and then we do 2 years of research. So I'll be finishing up my 3rd year in July and going off to 2 years of research and doing health services research. And, you know, the nice thing is I'll have weekends off and I'll be able to live a normal life. So that's definitely something I'm looking forward to here. And, you know, throughout my interview season, that's something that I was more open to. At first, I thought I just wanted to go straight through and finish, but like I mentioned before, like research, like Michigan's a research powerhouse, and I knew that I could come here and learn lots of skills that I haven't yet. But then the nice perks of that is that I can have a nice break. So.
Great, so I'll call on Daniela. Your thoughts?
As an intern, I don't know how much advice I could lend, but I think definitely, you know, go with your heart. I think a lot of us are type A. We like to focus on the little details and kind of categorize programs for whatever reason we think is important. But trust your gut feeling. And I will say, even through Zoom or virtual platform, whatever it was used, you can definitely trust that feeling. I think it definitely goes. You definitely feel like the real culture as you see people interact, even in the virtual platforms. So go with your gut feeling and trust it. As for what I'm looking forward to, I guess I'm looking forward to entering year ending. But in all honesty, I am looking forward to moving on to second year and you know, seeing the other side of intern year and like being what a senior resident, you know, learning that aspect of a career and kind of like going through the different electives and really figuring out what I want to do. So that's exciting for me.
Wonderful. Thank you, Daniela. Fitz, the last word, as it were.
Yeah. I think advice that I would give, well, one, I think don't underestimate the feeling of being comfortable, or that you feel like you'd be comfortable at a spot over prestige. I think sometimes a lot of us, as Danielle said, us being type A, we, especially going into residency, you might be like, oh, I'm gonna rank this program over this program because maybe it has a better program or it's ranked higher in this specialty or in the stuff I wanna do, but like, I don't fit in as much as I would at this program. And at the end of the day, I think the latter matters more, because residency is a grind and you need to be supported and you need to feel comfortable, and that will take you much further than prestige per se, or feeling like a program's ranked highly. Yeah. And then the other advice I'd give is just for intern year in general. I think one of the things looking back, I'm glad I did, is that on all my days off, especially when you're working so much, it's very easy just to spend it. I want to sleep. Let me just take a nap and not do anything. But I promise you, from a wellness standpoint, you should utilize those days off to go do something that makes you, brings you joy, hang out with your friends, whether that means just going and grab drinks, whether it means just seeing somebody in person, doing an activity, getting out of the house, because those are the things that will kind of keep you going throughout intern year, when it's the good and the bad, as opposed to just staying home. And it's very easy to kind of, when you're working 80 hours, just stay at home on your day off and watch Netflix. Sometimes you need those days. I'm not gonna lie. Like sometimes you do need to just binge for 4 or 5, 6 hours and then not worry about anything and be in bed all day. But I'm just saying, don't do that every day off. And then what I'm looking forward to is hopefully me being able to be in residency at a time where you don't have to wear a mask in the next year, 2 years. I don't know if this is inevitable. I really hope it's not, because one, sometimes it's just hot under that mask. And then two, it takes away, I see you're laughing at me, it is, And then two, it's like, it takes away from so much of the personal aspect of medicine, seeing our patients' faces, them seeing our faces, seeing our coworkers' faces. I think it was the hardest thing in transition for me, going into residency and like working with so many people. And although I've gotten very good to know people by their eyes, like it still would be nice to work with people when I know what they actually look like. So I don't know if that'll be next year, maybe it'll be 2 years, maybe it'll be in 10 years when I'm attending that we'll finally take masks out of the hospital, but it doesn't look like it's anytime soon, but that's what I'm looking forward to.
That's great. So my hope is that we're talking months, we're not talking huge expanses of time, but time will tell, fingers crossed. So Shukri and Daniela and Fitz, a huge thank you for taking the time and for sharing all your enthusiasm.
Thank you, Michael. Thank you, Michael, and thank you to all our panelists. Next, we're going to move to talk about some of the programs that we've created here to address healthcare disparities. So as part of our commitment to educating House officers around eliminating healthcare disparities, we developed a 10-month-long certificate program called the Healthcare Equity and Quality Scholars Program. This program addresses healthcare disparities specifically around 3 areas: cultural humility, social determinants of health, and now we address our vulnerable population. We discuss the biases that we bring to our vulnerable population when we see them. We discuss how systemic racism affects healthcare disparity. This program also includes a foundational instruction on quality improvement, because we think quality improvement is a foundational aspect of eliminating healthcare disparities. So we developed this quality improvement instruction that supports the trainees in developing a project designed to measure healthcare disparities and ultimately eliminate healthcare disparities within their domain. So I've invited 2 of the House officers from this current year. This is our second year of running this program. Dr. Neba is a House officer in the Department of Surgery, and Dr. Jenks is in internal medicine. And I've asked both of them to come and tell us why they joined the program. Sorry, my video went off and I didn't realize that. I've invited both of them to talk about why they've joined the program and what are they getting out of this program. I don't see Dr. Neba.
I'm here.
Oh, you are. Sorry. You're not spotlighted on my view. Thank you. I know you're on vacation, so thank you, thank you.
I'm glad to be here. Happy to help in any way I can. Hello to everyone. My name is Vanessa. I'm one of the second-year general surgery residents. I'm originally from the DC, Maryland, Virginia area, and I came here to Michigan, 1, because the people are the best people to work and train around, and 2, I just felt the most comfortable being here compared to other places that I interviewed at. But my interest in our Health Equity Scholars Program primarily stems from I wanted to get the training that I knew would probably help me as I progress through my residency program in terms of learning how to identify not only the areas within patient treatment and my patient populations that I felt were limited. As you guys can tell, I'm a woman of color, so there's certain things that I happen to be a little bit more sensitive to and I'm cued upon, and using my experience and the tools I learned from the program to be able to implement them within the general surgery like world and in our clinic and in how we generally take care of patients. Kind of a brief overview.
Hey guys, can you hear me okay? Just want to make sure. Yeah. Okay. Like Dr. Neba, I also joined the Healthcare Equity Quality Scholars Program because I wanted to kind of delve a bit more deeper into different disparities and learn them in a way that would be able to prepare me well for teaching them and incorporating them into leadership later on in my career, as well as directly, targeting disparities. My training so far, like before residency, I worked with a lot of underinsured or uninsured people and Spanish-speaking population and people of color as well. My main focuses, though, for me doing the project right now is in the LGBTQ plus or gender and sexual minority space. And so I really do like that the program essentially has experts trained in quality improvement project development, and they give us Zoom, I would say in person, but hands-on Zoom targeted feedback on what you're planning and kind of how to go about various disparities and what types of measures we have available, which is really interesting because a lot of things related to health inequities are so hard to do QI projects on just because if they're not in the system for whatever reason, they're hard to measure and really do things at a university level. And so it has been really helpful to get ideas of how to be more proactive about doing that. And I've enjoyed that. And the sessions too have been really great. I've learned a lot about even more about social determinants of health and how to take care of folks and really support them better if they're of a different religion or spirituality. And overall, I think it's been really helpful, and I'm excited to use the skills I've learned so far in curriculum development and leadership down the line. Also, sorry, my pronouns are she, her, hers, by the way.
Thank you. Just if you can say one thing you've learned from this program, especially around cultural humility, because it's a topic that we explore throughout the entire program. And I'll give you both 30 seconds, and then we're going to move on.
I think from my perspective is that we all have different backgrounds. We all come from different perspectives, and learning not to lean on your own personal perspective when you're interacting with someone. Because sometimes what you think could be an issue or what you believe could be the main talking point that you or a patient may have to deal with may not be the case. And like learning how to listen and be available to your patients is probably the best skill that I've learned in my transition from being like a medical student to being a resident, because as the resident, you actually have a lot of power in how impactful you can be in someone's life, and learning exactly what needs they have and learning how to serve their needs is a skill that I've learned. It's so important for me because yes, there are certain things I understand as a woman of color, but there are also things I am a cisgendered woman of color. So there are things that my trans brothers and sisters go through that I've never gone through and I don't understand, or that my Muslim brothers and sisters go through that I don't understand. So it's good to understand that you have to listen first and then see in ways in which you can be helpful to the communities that you serve.
I feel like she said it really well. I don't have as much to add, but the only other thing is, in doing that, of course, like meeting, the most important thing I think that we can do as doctors is meet patients where they are. And so that means like meeting them in their cultural, their spiritual, their background, whatever their experiences are, meeting them where they're at and trying to help them not just get where we want them to go from a health perspective, but help them get where they want to go and help them be able to value and still interact with whatever it is that's important to them to make them happy and healthy and like spiritually or from like a, whole person point of view. And so asking them like what their values are and, being open-minded, non-judgmental, of course, with every single patient you encounter is definitely going to do them a lot of justice. And then also, of course, making sure we're advocating for our fellow colleagues too. And if we ever see any, microaggressions, macroaggressions, discriminatory, language, anything, just making sure that you speak up for them and use your platform to help share it with people that don't have as high of a platform to speak on things. And so, just always, advocating for both your patients and your colleagues, I think is really important for the rest of your career. I do think that's part of our jobs as doctors.
Thank you so much. Thank you both for joining us and sharing your perspectives. Our next speaker will be Dr. David Miller. Dr. David Miller is the president, University of Michigan Health System. He's the executive vice dean of clinical affairs at University of Michigan Medical School. He's a professor in the Department of Urology and the committee co-chair for Michigan Medicine Anti-Racism Oversight Committee. Thank you and welcome, Dr. Miller.
Thank you, Dr. Perry. Can everyone hear me okay? Great, thank you so much. Am I able to share my screen?
Yes.
Thank you. Thank you. Are the slides visible now? Terrific, thank you so much. Well, thank you so much for the opportunity to join today, and welcome to everyone who's learning more about Michigan medicine and our tremendous training programs, clinical care, education, and research. And thank you very much for the opportunity. I'm going to present today on work being done across Michigan medicine through the Anti-Racism Oversight Committee. And I'm presenting on behalf of Steve Vinson, who's the co-chair of the committee, as well as many colleagues from across the organization who are coming together to advance our work and our efforts toward an anti-racist culture. I'll start by referencing a statement that we read with our Anti-Racism Oversight Committee meetings, developed as part of our committee. Leaders at Michigan Medicine support the institutional position that we unequivocally recognize racism as a public health crisis, and that we stand together against bias and inequality. We encourage everyone in the Michigan medicine community to join us in condemning harassment, inequities, and social injustice. The committee was established in...
Is it weird that I'm viewing this presentation?
I don't know if someone is unmuted. Sorry, I just heard something. The The committee was established in the summer of 2020 and had really three main charges. The first was to identify practices that contribute to racism and discrimination and recommend changes in Michigan medicine if needed. The second was to identify an approach that achieves an anti-racist culture and utilizes the diversity, equity, and inclusion dashboard to track the progress and outcomes. Third was to develop and recommend a plan around contributions we can and must make to eliminate racism and inequities that may exist today at Michigan Medicine. In support of this charge and based on feedback received from colleagues across the organization, 6 subcommittees were formed to advance our work. In a general approach of recognizing that significant work was being done in many areas around the organization, but there was a need and a desire to connect, catalyze, and accelerate this work. In the next couple slides, I'll share some details from each of the subcommittees and some of the work that has already been completed. Our Education and Clinical Practice Subcommittee has advanced a number of important initiatives and deliverables, including ending the use of race-based national and/or standardized clinical measurement practices. Partnering with the medical school, the Education and Clinical Practice Subcommittee has implemented a course for medical students on the history of race and racism. Our Community Work Subcommittee has been advancing partnerships locally, including our participation in the Healthcare Anchor Network and efforts to increase community engagement, the availability of clinical services, and investments in the Ypsilanti community. There's also been work to create a toolkit for development of new health equity and community engagement programs across Michigan Medicine. Diversifying the Workforce has been another important initiative. This subcommittee has focused in a number of areas, including the dissemination of a faculty hiring toolkit that can be used to assist with diverse recruitment across our organization. In addition, we've implemented exit interviews to better understand reasons why colleagues are leaving the organization and how we can change and reverse these circumstances. 3 additional subcommittees include Speak Up and Show Solidarity. This subcommittee has created a number of tools to facilitate speaking up and showing solidarity with colleagues when we see episodes of discrimination. This subcommittee has also created and socialized a leadership statement that supports our staff in speaking up. Opportunities for Conversation has created many different tools and scenarios for creating space for dialogue that ensures psychological safety for challenging conversations. And our Professional Development and Advocacy Subcommittee has led the development of an anti-racism curriculum that takes advantage of our concurrent work in the area of becoming a high reliability organization. Professional Development and Advocacy has also established a Facilitating Difficult Conversations workshop focused on conversations related to becoming an anti-racist organization. A key priority of our committee is to translate our oversight function into deliverables and ultimately change that becomes part of how we do our work every day at Michigan Medicine. And one of our key priorities has been to establish partnerships across the organization with existing teams. This slide summarizes many of our partners from across the organization, including our clinical leadership teams, community health services, the Office of Patient Experience, the quality department. All of these partnerships built around the concept of taking the work, the deliverables, developed through efforts of the subcommittee and translating them into the work we do every day across our organization, becoming part of our culture and leading to changes in our organization that are sustainable, both in the near term and in the future. We've also focused on identifying and describing what the anticipated impact of our work will be over time. How will this change our organization? And I'll share a few examples from this slide. First is the idea that building relationships and trust with diverse communities increases patient loyalty. And patient trust and concordance leads to better outcomes. It is also clear that more diverse and inclusive environments are more likely to recruit and retain talent. And we believe our efforts in this area are essential to creating a stable workforce connected to the work we do and leading to the best outcomes for our patients and the best experience for our team members. Research and innovation are also improved by diversity of thought, and the best research includes broad and diverse participation in studies and trials. Likewise, stronger understanding of and trust within diverse communities is reflected in our research opportunities. For education, an anti-racism focus will lead to better prepared learners and help us attract more diverse and top-tier students. Putting this all together, we believe strongly that this work will allow us to remain on the cutting edge as leaders and best. As we move forward, we continue to translate the work of our committee and the oversight provided by our committee into specific changes implemented at the unit level across our organization for sustainable change in how we do our work every day. This includes behaviors, this includes policies, it includes processes and changes across the organization. We also need to continue communicating the work of the Anti-Racism Oversight Committee across the system so there's a shared understanding of our principles, our progress, and the work yet to be done. It's also important to measure that change. I say often that we'll know we're making improvements when we see this both in data and in stories. That measurement comes in many forms. It includes dashboards, but it includes employee engagement scores, and it includes our patient satisfaction surveys, and it includes the stories we tell each other about our own experiences in our organization day in and day out. We continue to need consistent approaches to addressing patient bias in a way that's unambiguous and immediate. And then to connect the work of the Anti-Racism Oversight Committee with many other institutional priorities, including our health system priorities of building our base and our focus on belonging, access, safety, and quality and experience. Our efforts to become an accountable organization and as well as our continued work around high reliability. Putting all these steps together again to connect work happening across the organization, accelerate change, and being able to see this change in our experience every day, working in our organization, caring for patients in our organization, and taking care of each other in our organization. So that's my last slide. I'm certainly grateful for the opportunity to be here today to share
potential other things that may occur during the procedure. You could consider updating the patient's surrogate during the procedure if you'd like, but it's not really required per law.
And I thank you for your time and for the opportunity to join today. Thank you, Dr. Perry.
Thank you, Dr. Miller. It gives me great pleasure to introduce our next speaker, Dr. Malika Fair. Dr. Fair is going to give our keynote address tonight. Dr. Fair is the Senior Director of Equity and Social Accountability at the Association of American Medical Colleges. Dr. Fair develops programs and initiatives with multidisciplinary partners and local communities to advance equity, racial justice, population health, and accountability in academic medicine. She's also an associate clinical professor of emergency medicine at Georgetown, Washington University Medical School and Health Sciences. Dr. Fair completed her residency training and was a chief resident at Carolina Medical Center. She received her medical degree and master's of public health from the University of Michigan and her bachelor's from Stanford University. Welcome, Dr. Fair. Thank you for being here.
Thank you, Dr. Perry, and it's a pleasure to always come back to the University of Michigan, which is my home. I was born at the hospital. I'm from Ypsilanti, Michigan, which is right next to Ann Arbor, so it's always a pleasure to be back home. And it's a great pleasure to be with all of you. You all are in a really unique position of choosing where you're going to residency, and I'm sure all of you are familiar with the AAMC, which is where my primary job is. I'm sure at least a few of you have opened up ARIS. So I'm talking to you with my two hats from emergency medicine and from the AAMC. But what we're going to talk about today is advancing health justice, because even though the time that you have in residency is really short and you have a lot of time to master the clinical education, to really learn how to practice medicine, you have a unique role in advancing health justice. And I'm just going to be with you a really short period of time to give you a few ideas of ways to do that when you do get to residency. So let's see if we can start here. So I want to start with a personal story, which is a few years ago, a little bit over 2 years ago, I became a mom, and I have a really feisty 2-year-old who's upstairs who you may hear during my presentation, but I hope not. But this is concerning to me, this article on the screen, because if I take her to an emergency department anywhere in the US, based on these data that were done by colleagues at the University of Michigan, that she, as a Black child, is less likely than her white counterparts to be classified emergently, even if she comes to the hospital with the exact same symptoms. She's less likely to be admitted to the hospital, and she's more likely to have a longer wait time compared to her white counterparts. Now that's concerning, should be to all of you as clinicians, as a mom, as a Black person in the US. And so we have a role to play in medicine to ensure that all children are treated the same. And in fact, everyone is treated the same in our hospitals, and not just in our hospitals, that we can fight for health equity for all and health justice for all. Now, I won't spend too much time on definitions, but I do like this slide because it gives us a good picture of when we talk about DE&I and we talk about anti-racism and equity and justice. You know, and the picture on the left really shows what equality is, and people, especially in medicine, we talk about treating the same patient, everyone the exact same every time we go into the room. But equity gives us a little better picture of what that means. And I heard a lot of the previous speakers talk about how equity is introduced into Michigan medicine. And what we're headed towards across academic medicine is justice, so that we can remove the barriers that prevent individuals from reaching their goals. In this case, health goals, but that includes career goals, educational attainment goals, so that each of you can finish residency and become the clinicians that you want to be. But I want you to remember this picture on the right, because even though you will be deeply embedded in a very busy residency program, you also have a role to play in breaking down those barriers. Now, I include this picture here because I'm sure you all have learned how to read an EKG. For some of you, this will become second nature in just a few months. But as residents, you will have the pulse of your entire hospital right there. You will spend more time in the hospital than some of your attending colleagues. You will see the faces of patients and hear their stories, and spend even more time getting the pulse of what's happening in your hospital, the inequities they'll be right in front of you, and the inequities that are happening in the communities that you serve. And because of this, you have a unique responsibility. So I'm going to give you 4 ideas today of ways that you can at least organize some of your approaches to advancing health justice over the next 3 to 7+ years. The first is in your clinical care. Now, you may be familiar with this. It's a fairly old article or a fairly old report now, but it's a landmark report. Came out in 2002 from the then Institute of Medicine, now National Academies of Medicine. But it was one of those reports that told us for the first time that this health disparities discussion is not just in society, it's also happening in the hospitals and where we practice. And even when you account for social economic conditions, you still cannot account away for the differences in the quality of care that patients are receiving based on race and ethnicity. So this makes it our problem too. Now, you would hope that if this report came out in 2002, that we would have made progress. But unfortunately, in this 2019 report, you see that data from ARC has been measured over time, and these same quality metrics keep showing inequities in care by race and ethnicity in our hospitals nationwide. So what is one thing that you can do? And this is not the whole picture by any means, but it is an individual physician level responsibility to address the biases and to mitigate the biases that you have when you are at the bedside. I'm not going to spend too much time on this because I've got to fly through these slides, but there is this report here that you can download, and I'm happy to share the slides, give you strategies to use as you're walking into the room. We all know that when we go into the room, we immediately can size up a patient based on their age, their gender, their race, their ethnicity, the clothes that they're wearing, and the way that they're speaking. But we have to acknowledge those biases that we have and employ strategies to ensure that we are hearing our patients, that we are really finding out what's going on with them, and that we are treating them in an equitable fashion. The other thing I want to point out is quality healthcare. And we heard a little bit earlier from the health equity scholars, and I know from residents across the nation that you'll have opportunities to participate in quality improvement within your residency program. And this is another landmark report that came out in 2001 from the Institute of Medicine, that then now the National Academies of Medicine, that really gave us an idea of, well, what does quality of care look like? What does quality improvement look like? It should be safe, it should be effective, patient-centered, timely, and efficient. But unfortunately, equity has been left out of the quality improvement discussion. You all have an opportunity to bring it back, as you will probably all be involved in some sort of quality improvement in project during your time in residency. You have to ask the question, are there any differences between groups? Is anyone going to improve their health outcomes by my intervention? And is anyone going to get worse because of it? And look at data by race, ethnicity, languages spoken, insurance status, zip code, etc. This is an example from our colleagues at Washington University in their internal medicine program in their continuity clinic. And they asked some of these same questions. You know, if we are treating our patients with diabetes, are we giving the same level of care to all of our patients? Are we doing our nephropathy screening and our ophthalmologic exams? And you can see the scorecard on the slide here, and it's not always equitable. And so what they did is came together as a team and made sure that they were going to address these numbers and keep it front and center in front of the team so they could work together. Now, finally, I won't spend too much time on this because this is an area in particular that Michigan Medicine has been one of the national leaders, but hopefully you saw this paper that came out in the summer of 2020 in the New England Journal of Medicine that really was a calling to all of us to pay attention to the clinical algorithms that we use when we are practicing medicine. Just a few on the slide here, but you know, even as a mom, as I mentioned, at University of Michigan, I know that the faculty in the OBGYN department were one of the first in the nation to remove race from the VBAC score, and then the national community followed suit. You all as residents and as students have been the champions across the nation. We've seen examples of when students and residents are speaking up that entire institutions are following their lead. And so we encourage you to continue to do this wherever you end up in residency. And I include this slide as a courtesy because I do give talks to patients and to the business community. And I've told them to ask you all questions when they show up in the emergency department, when they show up in the OR, before they go to the OR. Because it is our responsibility as physicians to be able to explain the health inequities of whatever condition that we are treating. It's not just for those faculty who happen to have an interest in this topic. It's something that we all have to know about and be able to explain it to our patients. They also can ask us, are you making any decisions based on my race? Are you using any clinical algorithms that you had to check a box that I was Black? And we have to be able to justify if we're doing that and why. And then finally, what strategies are we employing at the bedside to mitigate bias? We all have them. And I should be able to tell my patients, you know what, you're right. And this is what I've done today to ensure that I'm hearing you and I'm not treating you just because of your race or ethnicity. Now, the second area is education. We also heard a lot of examples about what Michigan Medicine is doing to ensure that you as residents will have the education that you need to be advocates in health justice. Now, I want to give you an example of what is just happened. This on the slide is January 18th. You know, we in this nation have a lot of examples. We think about historical examples of racism in medicine and justice in medicine. This is a present day example of how some of our colleagues have been giving ivermectin to patients in the carceral system without their knowledge and telling them that it's vitamins or antibiotics. And we had a lot of conversations and still having in the pandemic about trust and trustworthiness and why patients aren't trusting us anymore. Well, it's not just because of the Tuskegee experiments. It's because of present day injustices that our community is still involved in. And so I think it's important that you as residents, that we as a clinician and medical community, that we are committed to learning about injustice in medicine and that we are aware of what's has happened historically and what continues to happen contemporarily. These are a few ideas of things that, yes, it is the responsibility of your institution to ensure that you're learning these topics, but our process is a lifelong learning. So you as individuals have to be committed to knowing what you see on the screen here too. And starts by acknowledging that race is a social construct, that there's no inherent link to biology. And even though there's genetic ancestry that we know is where you come from in the world or the region of the nation, there's no Black gene, there's no Latinx gene. But because it's still involved in the hidden curriculum in medicine, and we have to ensure that one, we unlearn this and that we continue to teach this. Secondly, that we also understand the history of racism in medicine and how it impacts clinical practice. Now, I'm focusing on anti-racism particularly because this is an area that we see across our nation that our institutions are doubling down and ensuring that specific anti-racism principles are included in medical education and across all of our mission areas. You may be familiar with a study that came out in 2016 that showed that residents and medical students who graduated in 2016 still believed that Black people didn't experience pain the same that white people did, that our skin was thicker, that our blood was clotting faster, and that we just didn't experience pain as much. And that, I hope, is disheartening to you as it is to me. But because these ideas still exist in present day, we have to be committed to ensuring that we unlearn these myths and that we're practicing anti-racism. The fourth area is acknowledging our privilege and dismantling that privilege. And that starts with acknowledging white privilege, gender privilege, class privilege, even our physician privilege when we walk into the room with a white coat, and making sure that we employ strategies to both acknowledge that and to put ourselves at a level playing field with our patients and with our colleagues. It can't just be this 20-minute talk you're hearing from me today or a few lectures that you might hear in residency, but this has to be a longitudinal commitment for all of us. And I heard one of the speakers say earlier how important it is to think about the community that you're going to be practicing. Whether you choose to come to Ann Arbor or you go to another hospital, the population that you serve might be very different. And understanding the context of the patients that you are taking care of is extremely important if you want to be committed to anti-racism and not just a general, what we used to call cultural competency. Now, you may be thinking, okay, these are great, lofty ideas. I'm not really sure how to put this into practice. Fortunately, at AAMC, we have released several competencies, so you can get a sneak peek and say, where should I be when I'm graduating from medical school in a few months, and where should I be when I'm finishing residency? We have 3 sets of competencies that are out. The first one you see on the screen is related to quality improvement, and there's a whole section on health equity and quality improvement and patient safety. The next is around telehealth. And telehealth had a big year in 2020 and it's here to stay. And these are some principles that we should all know related to telehealth and access and equity. And then finally, we just released the diversity, equity, and inclusion competencies. The report is forthcoming, but there is a link to the full set that I can, that's on the bottom of the slide, but I can also share afterwards. And it gives you a sense of where you should be, how you should challenge yourself, and what is expected of you as a graduating medical student and as a resident when you're finishing residency. The third area is community collaborations. And I heard a lot today about how important it is to engage with local communities. You may have heard about the tripartite mission of academic medicine. You've all experienced it, and that's the clinical care that you're providing, the research, and the education that we are teaching you and that you are a part of. We've put out an article in the fall that stated that those 3 areas are not enough, that we have to be committed as academic medicine to our community collaborations if we really want to improve health outcomes and especially to achieve health equity. Now, what does this look like? I would encourage all of you, before you step foot on July 1st or around that time, to look at the community health needs assessment of your hospital. It is readily available for all not-for-profit hospitals in the nation. And this is the one for Michigan Medicine and the hospitals that are in the area. But it will give you a sense of, what are some of the needs of the local community that you are about to be taking care of. If you already have an idea that you want to volunteer or you want to partner with community organizations or even do a research project, I would start here because this gives you a sense of what your work what work you are interested in and how it can be actually helpful to the community that you are about to serve. And you may be thinking, residency is extremely hard. I'm going to be putting in a ton of hours. I'm barely going to have time to see my family. How am I going to be able to solve homelessness, transportation issues, food insecurity in the carceral system? We're not asking you to do that. But I do think it's important for you to pause and think about what is your role and where do you want to put your emphasis in? Our emergency medicine colleagues out in California at Highland came out with a really great article where they've defined this terminology for us. And they described that Where medicine really is furthest to the left, where we are addressing social needs. You know, in the ED, we are oftentimes, if someone is hungry, we will give them a meal. If someone needs a transportation, we'll give them a voucher for a cab voucher. If someone needs housing that night, we'll make sure that the social worker comes in and make sure they have a place to go. But we are trying to push academic medicine further upstream, even just to see how we can reduce social risk for our patients. For instance, for someone who doesn't have stable options, housing options, maybe they have a place to stay tonight, maybe they have a meal today, but they're food insecure. There are a variety of ways to do this, but I urge you to think about when you choose where you're going to residency, what partnerships does the institution already have with community organizations? How are these organizations partnering with the hospital to ensure that the social risk of the patients have been reduced, and try to work with those organizations? Several organizations have medical legal partnerships where they also have attorneys that are on staff who are addressing these health harming legal needs, and that's one way to go, but it's not the only way to address social risk. And then finally, we talk a lot about social determinants of health, but this is the furthest upstream. And this is what I hope all of you can get involved in at some point during your residency. And it's not just with communities. This really takes you working in partnership with communities, but also advocating. And that's our fourth area. Now, again, 2020 was a year where I saw more physicians being involved in advocacy than ever before. White Coats for Black Lives. This is a picture from where I practiced at GW, where our clinicians were bending with one knee in their white coats. And we saw examples like this across our nation. And hopefully you all are participating in demonstrations such as these, but it doesn't stop here. It involves reaching out to your local legislators and thinking about, well, what do I want to advocate for on behalf of the patients that I'm serving? In the District of Columbia, we are fortunate enough to gather all of the medical schools and teaching hospitals in DC who have an interest, and it's all of them, in improving health equity in the nation's capital. And the report on that, on what we learned from that roundtable is on the left. But one example was really striking, and it was from our Teaching Health Center, which is a residency program, a family medicine residency program embedded in a federally qualified health center in the district called Unity. And those residents have a regular rotation where they are able to engage in advocacy and justice-related issues locally. And the report that you see on the right is the health equity report from the District of Columbia, put out from our health department called DC Health. And they've identified several social determinants of health, but what you see here on the screen is our bike share access. Now, this is having one form of transportation in the district is extremely important, and it's highly available to those who live in more affluent areas, which is the upper left parts of the slide here in the diamond of the District of Columbia. But if you look on the lower right areas, you see less blue lines. It's because we have less transportation in Ward 7 and 8, where I lived. And this is an area that our residents were able to meet with City Council, they were able to advocate, and were able to get more bike share access for their patients. This is just one example that it's not beyond you, that even when you're a resident, you can identify some needs for your patients, you can advocate and see change to help improve health outcomes in your area. Now, I know I was talking fast. I hope that we still have a time for a few questions here, but I think it is definitely part of your responsibility, and I'm calling and urging you all to think about your role as residents. Congratulations on almost finishing, and I know this is a stressful time, but I echo one of my colleagues who talked earlier. Follow your heart when you are making this rank list, and best of luck to all of you. Thank you.
Dr. Fair, thank you and thank you and thank you so much for always being willing when I come calling. Yes, and I'm sorry that sometimes I abuse the privilege of having your cell phone number. So, but thank you for sharing your knowledge and for inspiring all our students and house officers. If anyone has a question that they want to ask real quickly, we can take a question in the chat. We're running a little bit behind. I want to also thank Sue and the entire office for health equity and inclusion, who worked really hard to help me organize. They have outstanding organizational skills and have supported this program from start to end. We're going to ask you to join your breakout rooms of your choice. The rooms will be by medical specialty, and they'll be hosted by faculty and residents in your department that you're interested in. You can continue this conversation during your breakout session. You can ask further questions about the program, about Michigan, about health justice. And again, thank you for your time. Some of you are in other areas of the country where it's dark or light. And I know you have busy schedule during this interview season. So thank you for taking a second look at Michigan Medicine, and go Blue.